Thanks everybody. I'd like to thank Victoria, Anna and Joe and Ovacome for asking me to present today. When I started at the Christie 36 years ago, and it wasn't as bad as Michelle's starting in 1809, but anyway, the Christie was pretty much this bit here, and ovarian cancer was a single illness that we treated with platinum that had just come in, and some alkylating agents that you may or may not have heard of, cyclophosphamide and melphalan. Melphalan definitely gone. So what's happened over the next 36 years is that we've understood, just like Victoria was just saying, that ovarian cancer is now not one disease. It's a number of different diseases that are controlled by the genetic abnormalities that are present that make those different cancers behave in those different ways. Now, because of that, I'm just going to cover what's happened in 2025, but the presentation that I'm going to give you is actually separated into different chapters, so I'll have to go through it slowly because so many cancers, there's been so much progress, so much is happening medically. I'm saying obviously the surgical progress that Michelle just presented, but we're going to focus on the medical things. So the first thing I'm going to talk about is one of my colleagues' trials, which may be the last general chemotherapy trial that we see. Then going on to the era of antibody drug conjugates, and I'll explain what those are as we go through it, because this is the way I think cancer treatment is going now and will go in the future. I'm going to talk about the poor results that we've seen with immunotherapy so far, where we might take that, then move on to a new target that's just come out, published in The Lancet a few weeks ago, then go on to low-grade ovarian cancer, and lastly focus on my own program, which is focused on antivascular drugs, and then just finishing on how do you access clinical trials in the UK. So because we are now focusing on the molecular mistakes that are inside cancer, so if we accept that the problem with cancer is it's a disease of the genes, which is like the computer code inside the cells, the code produces proteins, those proteins don't work normally, but the errors are different in different cells. But chemotherapy is like a general DNA damaging agent. And because we're moving away from just giving non-specific drugs like that, this might be one of the last trials that is of just straight chemotherapy in ovarian cancer. So this study is called ICON-8B. It was presented in Berlin just 2 weeks ago, so you won't find it in the press. You might find it in the press, but you won't find it published just yet. It's only just been presented. And in this study, my colleague Dr. Andrew Clamp at the Christie, recruited patients who had stage 3, looking at this in the top left box, stage 3, which means illness in the abdomen, or stage 4, which means it's spread elsewhere. And the patients had to be pretty fit, reasonably fit, and able to receive chemotherapy. And the patients were randomized between the standard, so many of you will know that the standard way that we give chemotherapy is every 3 weeks, established for almost 100 years. Carboplatin, paclitaxel, and bevacizumab shown in blue, with the paclitaxel given every 3 weeks. That was the blue arm, was the control arm, in other words, the standard chemotherapy. And the trial randomized patients to either 3-weekly paclitaxel, shown here, or weekly paclitaxel, shown in green. And that trial has shown that there is a slight advantage in giving the combination together. So this is in the first line setting. And what we're seeing here is that there's an improvement in controlling the illness and in outcomes as well. Now, this trial was set up prior to the introduction of bevacizumab and olaparib combinations that we use in certain kinds of the illness that we can come back to in question time if needs be. Having said that, we anticipate that this will come in as a first-line treatment, and patients and their oncologists will say, why don't we just add in PARP inhibitor if your illness is HRD positive, which means homologous recombination deficient positive, which is the way that we categorize tumors. Again, I can come back to explain this at the end. But the reason I'm showing this might be one of the last just straight chemotherapy trials that you see. We've tried over the years, we've tried drug A, B, C through to Z to try and change this, but it's roughly speaking stayed about the same in terms of its efficacy. Now we're seeing that this combination is there, but I'd like to highlight that bevacizumab is part of this, and I'll come back to explaining that later on. To be honest, it's my research interest, which is why I'm highlighting. Okay, so the reason I said that this might be the last chemotherapy trial that we see, just straight chemotherapy, is because we're now entering an era of antibody drug conjugates. So let me just go through this for you. If you look at the top left, this is a general structure of an antibody. If you imagine a capital letter Y, the two arms stick up in the air, and those two arms bind to molecules, usually on bacteria, and that's how bacteria are killed, by these antibodies that bind to the bacteria. And then the stem, the feet, if you like, of the antibody, bring in the immune system to kill the bacteria. But because we were able to, in the 1970s, to clone these antibodies, we're now able to make antibodies against anything you like. So in this case, what the investigators have done is to take an antibody directed against a molecule called the folate receptor, which is a vitamin, folic acid, that we give to pregnant mums, but is actually heavily expressed in ovarian cancer, which happens in a different age group. But not only are we bringing in the immune system through the feet of the capital letter Y antibody, now we've got chemotherapy drugs bound to the Y of the antibody. So the drug is then homing in to the cancer cell, homed in, and then the chemotherapy is taken into the cell and then kills the cancer cell. So the way that this works is that we give an injection or a drip of the antibody drug conjugate, so antibody drug, the chemotherapy drug conjugate, bringing it all together. And that goes into the blood, into the blood vessel and leaks out like it does normally. And the antibody then binds to the cancer cell and, whoops, it then vanishes altogether. Then it comes back again. And the antibody is then brought into the cancer cell where it's digested slightly and it releases the chemotherapy drug. Now the chemotherapy drug hopefully kills that cancer cell, but it's then released and has what's called a bystander effect on the cancer cells next door because there's a disproportionate concentration of the chemotherapy drug next to the cancer cell target. Now, as I said at the beginning, the whole point of antibodies is usually to fight bacteria. And in this case, we're trying to fight a cancer cell. So the same principle applies. We import the immune system, bottom left, to attack the cancer cell because the antibody's bound to it. Now, the whole idea of this is to try and target the cancer cells that express particular molecules. And the one that you may have heard about is called mirvetuximab. And that binds to the folate receptor that's heavily expressed in about 50 or 60% of ovarian cancer, particularly 30 or 40%. And we know that if the cancer expresses the folate receptor at a high level, it's particularly sensitive to mirvetuximab. And it's that particular group that benefit the most from the drug. Now the problem is, although we thought these drugs would be like magic bullets, they would home in specifically on the cancer, you're still giving chemotherapy to the patients. So patients still get some side effects. And this one has a slightly unusual side effect of blurred vision because it's affecting the surface of your eye. It can still cause some diarrhea, nausea, fatigue, and blood counts. The data that look exciting are that for the first time, we seem to have changed the outlook of platinum-resistant ovarian cancer with this drug. That's what the randomized trials showed. That's why it's been approved in America, and it's coming before NICE in March 26. That's when they should be coming out with a conclusion, and we hope that this then becomes available for our patients in March this year. Now, if any of you have friends who are going through treatment at the moment, they may have been recruited to a trial called Gloriosa. And Gloriosa is a trial in recurrent ovarian cancer where mirvetuximab, the same drug, is given to patients with recurrent chemosensitive ovarian cancer with or without bevacizumab. Now, the reason I'm telling you all this is not just to tell you about mirvetuximab, but to tell you that this is one of a huge number of drugs that are coming through. We're transitioning from looking down a microscope and saying, this is ovarian cancer, to saying, okay, this is ovarian cancer that expresses the folate receptor, mirvetuximab might be a good treatment. But there are other drugs as well. So you know already from breast cancer treatment, drugs like trastuzumab, which you'll have heard of as Herceptin, has been used for some time, and now Herceptin, or trastuzumab, is being given with an antibody bound to it. We're seeing multiple targets being used. And what makes this exciting for us is the drugs that are, the types of ovarian cancer that we understand to be chemo-resistant, like mucinous and clear cell, we've got antibodies against molecules that are expressed on those cells. So you can start to see how we can target the difficult tumours, the more chemo-resistant tumours, by targeting molecules that are specifically expressed on those difficult tumours. So this is the era that we're moving into, the era of antibody drug conjugates, of which mirvetuximab in the ovarian world is the prototype. Okay. So, I'm going to change subject now, I'm afraid. The question is, why is it that in high-grade serous ovarian cancer, we have not had much luck with the immune drugs so far? And to understand this, we need to start with what is the normal situation. So that's shown on the left here. This is an interaction between an immune cell in our body and a normal cell. And obviously you don't want your immune system to fight your body. That would be a situation called an autoimmune disease like rheumatoid arthritis or SLE. That's when your immune system starts to attack your own body, autoimmune conditions. So the question is, how do you stop the immune system from attacking self, to stop attacking yourself? You want it to attack infections or cancers. So you can see on the left here, you've got an immune cell that's bound to a normal cell. The immune cell is engaging a normal cell molecule, but there is what's called a checkpoint, which is this PD-L1, PD-1 and PD-L1. And this immune checkpoint is saying, don't attack me, I am self. So that's how our bodies, this is an example, the major one from the cancer point of view, this is how our bodies stop our immune system from attacking self using these immune checkpoints. So now we know that that checkpoint is there and stopping the immune system from attacking ourself. We can then develop treatments that block that checkpoint. And these drugs, now shown here on the left, this system here, we can develop antibodies either against PD-1 or PD-L1 that stop that self signal to say this cancer cell is foreign. Now, obviously you'll realise that when we break that, but when we give what's called an immune checkpoint inhibitor, these are antibodies that we give to break that tolerance system. The side effect, which we see in about 5% of patients, is that we do induce autoimmune conditions. You do get autoimmune conditions as a side effect of these drugs, but it's actually not that common. Now, what we also need then is the immune cells to be present, but we also need something foreign, some abnormal protein that the immune cell sees and says this is abnormal, it shouldn't be here. Now, if you smoke or you go in sunlight, there are mutagens in the smoke or in the sunlight that cause abnormalities, and that makes lung cancer particularly sensitive to this sort of treatment. It makes melanoma, which is a type of skin cancer, particularly sensitive as well, because those conditions, the smoking or the sunlight, cause abnormalities, creating new molecules to which the immune system can work. And that's why this class of drugs, these immune checkpoint inhibitors, to try and break your recognition of self, have made such a difference in certain cancers, bladder, liver cancer as well. So, the question is, why does this not work in ovarian cancer? And the problem is, do we have immune cells present? We need these three things to be present for this system to work. Immune cells, yes. We've known for years that the more immune cells you have in an ovarian cancer, the better the outlook for the patient. Is the immune checkpoint, the PD-1 and PD-L1, present in ovarian cancer? Yes, it is. The problem is that the abnormalities you get in high-grade serous ovarian cancer, which is the most common type of ovarian cancer we see in adults, are due to DNA just being multiplied loads of times. It doesn't make new molecules, it just is disordered. There's loads of copies of chromosomes, it's all in a muddle, but the molecules that it makes are not abnormal. So the problem in high-grade serous ovarian cancer, and the reason that immune treatments just haven't worked, is because we don't have these new molecules. You need the three parameters. Immune cells, yes. PD-1 and PD-L1, yes, they are present in ovarian cancer, but we haven't got the new mutated molecules to which the immune system can respond. So I hope I've explained that okay. So, we have done loads of trials. If I say we, it's the whole medical oncology community globally. And loads of trials in the first-line setting, in the current tumour setting, loads of different trials. The bottom line is there are very few abnormal proteins in ovarian cancer to which you could activate the immune system, so it doesn't work. Immunotherapy trials have been disappointing, so what can you do about it? So there's a number of things that are being done at the moment and are ongoing. So if you look on the left-hand side, you can say, well, we can use drugs that sort of damage DNA, see whether they can create some new molecules. And they could be PARP inhibitors, given with immune drugs, or we can wait till patients have had loads of chemo, because we know that that'll create abnormal molecules to which the immune system can respond. So, largely speaking, the PARP inhibitor trials with immune therapy trials, they're quite early. DUO-O was a trial conducted by AstraZeneca where they tried really throwing everything at it. So that's bevacizumab, immune drugs and PARP inhibitors. And yes, you did see an improvement in terms of control of the illness, but a couple of weeks ago in Berlin, the first results came out and said it may not be as good as we hoped it was. So it's early, keep an eye out for it, but I'm not sure it's going to work out. The next thing is, what about giving these drugs to patients who've had loads of chemo? Because the chemo will cause new molecules to be formed by damaging the DNA. Those trials were all negative, again, until the trial in Berlin that was presented a couple of weeks ago, which is called Keynote B96. I understand that this talk might be available on the website because there's lots of references to different things that you can look up if it's of interest. And that trial is positive, but this is the only one. So we are waiting to see what happens when this trial gets written up. So far, the trials in recurrent ovarian cancer and chemo-resistant ovarian cancer have not translated into improved outlooks. So we've tried really hard with high-grade serous ovarian cancer, but the fundamental problem is we haven't got the molecules to which to activate the immune system. And yes, you will have heard about cell therapy, CAR T cells. This is at a very, very early stage, so it's nothing that's actually going to be in the clinic, mainstream clinic, for some time to come. So what else could we do with the immune system? And the answer, I think, may be that we start to look at different types of ovarian cancer. As I said to you at the beginning, ovarian cancer covers a multitude of different types of tumours, and some of those include clear cell carcinoma, which has a different genetic abnormality completely from high-grade serous ovarian cancer. Now, there are 3 trials that are of interest that have come out so far. And the first one, the most important one, is the MOCA trial, which was a randomized small study, which actually didn't show that the the immunotherapy was much better than standard chemotherapy, but still, the side effects of immunotherapy are that much less than giving chemo that you might actually want to go down that route. However, our colleagues in the UK have carried out a study called Peacock, which looked at pembrolizumab in clear cell ovarian cancer, and that has shown quite a good response rate. But perhaps most excitingly, another study, which I can't remember what the acronym stands for, called the MOST Circuit, looked at treating patients with clear cell gynecological cancer. So not necessarily ovarian, but there were a lot of patients with ovarian cancer in it. And they treated with 2 different drugs. So I've told you about PD-1 and PD-L1. In this trial, they combined that checkpoint inhibitor with another one called CTLA-4. So they gave 2 immune drugs, which is quite a tough combination. And there they were starting to see really good high control rates of clear cell carcinoma. So again, by looking at a different illness with different abnormalities, we're in a position now to say, let's do these trials and see whether we can actually improve the outlook for our patients. I think this might be the most useful way forwards for immunotherapy. So, changing subject again. In the Lancet this summer was the first of a publication looking at steroid receptor antagonists. So if you have chemotherapy, the chemotherapy goes into the cancer cell and hopefully it damages the cancer cell or kills it, leading to the release of molecules that trigger the immune system to come in, like I was saying before. This is all chemo now that we're talking about. Now that whole system of chemo damaging a cell and the immune system being brought in to mop up those damaged cells can be slightly reduced through a type of steroids called glucocorticoid steroids. And these are all within cells, if you like. And what they did in this study of the drug called relacorilant was to give an inhibitor of the receptor for those steroids, glucocorticoid receptor called relacorilant. If you get the study, I've put the URL for the study on the bottom of this page. Hopefully you can capture it from there. So relacorilant was given with a drug called nab-paclitaxel, which is, and you might have heard of it as Abraxane. It's a different sort of version of Taxol. Patients were allocated either to receive nab-paclitaxel or nab-paclitaxel with relacorilant, and there was a slightly better control of the cancer, but at an early stage, the overall outlook looked better, and this was good enough to get published in the Lancet. So I think this is early, their follow-up is early, but one to look out for as we go forwards. Patients in this study had quite a bit of previous treatment, and previous bevacizumab and taxanes as well. So this is a new target, one to look out for. I think one of the issues that will need to be resolved here is how patients can take steroids at the same time, because this is a steroid blocker. So this needs to be resolved with this class of drugs. How does it interact with steroids that we give as antiemetics to our patients, anti-sickness drugs? Nevertheless, this was the first of a new class of drug. So I'm sorry to do this again. We're now going to jump to low-grade ovarian cancer. This is all that's happened in 2025, pretty much, or what's going on in 2025. So to understand that, I need to just tell you a bit about what goes wrong in low-grade ovarian cancer. So I'm just showing the anatomy here and an example of a tumour, which is a mixture of tumour cells and immune cells, immune infiltrating cells. On the surface of, say, the grey cells, which are meant to represent the tumour, there are molecules that, like chicken drumsticks, I'm just showing these here. These chicken drumsticks are actually what we call receptors. They sense a protein in the bloodstream called growth factors, of which there are hundreds of different growth factors. These growth factors are like hormones. They signal to cells to behave in a certain way. They bind together, the chicken drumsticks form pairs, and then they, through these molecules on the inside of the cell membrane, they send messages into the cell to say, multiply, don't multiply, or whatever. Now, if that's okay, I'm just going to change to this cartoon now. So the chicken drumsticks here are shown as two turquoise ovals in the cell membrane at the top. What happens is when those receptors come together, they send a message through a cascade of proteins. It's a bit like a snooker table where you hit 4 balls, 1, 2, 3, 4, in order, and eventually the 4th ball goes into the hole, if you can accept that analogy. So the growth factors activate those receptors at the top of the cell. They then activate RAS, RAF, MEK, and ERK, and then eventually that results in cell multiplication. That's the normal situation, so cells don't multiply unless they get the right signals coming to them from growth factors, which are like hormones. I hope I've explained this okay. So the problem in low-grade ovarian cancer is, again, it's a genetic illness, but the gene abnormalities are code for abnormalities in these two proteins, RAF and RAS. So instead of needing growth factors to stimulate cells to multiply, they don't need it anymore. The cells start multiplying on their own because RAS and RAF are switched on. So you don't need the growth factor. As a result of that, that's why you get low-grade ovarian cancer. It's these abnormalities that are there. So for anybody who knows anybody with low-grade ovarian cancer, we may well have known about drugs that we give called MEK inhibitors, so-called trametinib. So we've been using that for some time. It has quite a bit of side effects, and so that we're always looking for drugs that are better than that instead. So as these two molecules, RAS and RAF, are mutated, new drugs are being created. And one of these drugs is called avutametinib, and avutametinib inhibits both RAF and MEK. In other words, hit 2 targets along the way, try and really switch off that whole system. But the problem is, when you switch off that particular pathway, nature doesn't rely on a single pathway, so you have backup systems inside your cells. And there's another one, you have to be careful how you say this, but this stands for focal adhesion kinase, FAK, and that activates a different pathway in trying to back up what this system would have done if it was switched on properly. So there are backup systems that are around, and as a result of that, the investigators have combined not just avutametinib, but another one with defactinib as well, to try and switch off this pathway. So I hope that we've explained it okay to you. Normally there's a cascade of proteins that lead to cell multiplication in the normal situation. In low-grade ovarian cancer, these mutations result in those molecules being switched on all the time, so you get signals to the inside of the cells saying you've got to multiply all the time, and that's the genetic error, the biochemical error inside low-grade ovarian cancer. So we can try and stop that by giving avutametinib, but the backup system kicks in, and we can inhibit that with defactinib as well. So as a result of this, these 2 trials, the FDA have now licensed this combination for patients who have abnormalities, particularly in RAS. So in America, this combination is now approved for KRAS, which is a particular type of RAS molecule, mutated low-grade ovarian cancer. And the reason for that is because they saw the highest response rate, in other words, the highest chance of the illness coming under control in patients who've got RAS abnormalities. And you can see why. It's at the top of the cascade. This is driving the cancer, but if you give a double hit down here and switch off the backup pathway, you're going to really control things nicely. And that's resulted in the best response rate we've seen so far in low-grade ovarian cancer. The trial that was conducted was called RAMP 201, and the RAMP 301 trial is just open again at the moment, trying to recruit the last few patients to that study. But what we hope is that we will see this coming through, this combination for our patients, which is pretty well tolerated actually, presumably for patients who've got that abnormality in RAS. Okay. Over the last 20 minutes or so, 25 minutes, I've talked about a number of drug systems, say the first trial that Andrew Clown presented of carboplatin paclitaxel with bevacizumab, where bevacizumab, an antivascular drug, was being used, and mirvetuximab, the antibody drug conjugate, is now being examined with bevacizumab, and you can mix it pretty much with all chemotherapy drugs. My research, which over the last 25 years has been focusing on understanding how these anti-blood vessel drugs work and which patients benefit from it. So I'll just give you some background on this. As a tumour grows, shown on the left, it changes from being avascular and dormant, shown on the left, this small little microscopic group of cells that just takes oxygen as it diffuses out of the local blood vessels. And it doesn't need any blood vessels itself, and that explains why antivascular drugs don't work if you have very early cancer. You have an operation to remove it, say an early breast cancer, you might have microscopic deposits left, but anti-vessel drugs don't work when the illness is at a microscopic level because the tumours don't need a blood supply. But at some point the tumour grows, and when it starts to experience low oxygen levels, a signal develops inside the cancer that is due to this growth factor called VEGF, vascular endothelial growth factor, that causes blood vessels to form inside the tumour. And that allows the tumour to grow and potentially also spread to other organs as well. So inhibitors of VEGF were developed 15, 20 years ago, and of which the most well-known is called bevacizumab, Avastin. But there are other tablet versions of the drug that we can give as well. Cediranib as well, that we've been using a lot in our clinical trials. The oral drugs have more side effects than the antibodies. But what we've seen with these drugs is that they have widespread usage, potential usage in ovarian cancer. The drugs inhibit VEGF. We know that they work in the first-line setting, but they also work in recurrent platinum-sensitive illness. They also work in chemo-resistant ovarian cancer as well. And importantly, they can be reused. So anybody who knows about PARP inhibitors will know you can't really reuse PARP inhibitors. Once the effect's been lost, the cells tend to have acquired resistance, and therefore giving another course doesn't work. That's not the case with bevacizumab, because we're treating effectively normal cells, blood vessel cells. They don't necessarily acquire resistance, so you can reuse bevacizumab. But sadly, in the UK, we are only able, in England, to use bevacizumab to treat patients in the first-line setting. In Scotland, they have it potentially available in the chemo-resistant setting, but we ought to have it freely available for all of our patients on a recurrent basis. So the mechanism that we've been focusing on now for some years is that there are lots, as I said before, nature doesn't leave a single pathway to control something as important as blood vessel formation or growth or cell multiplication. So there are lots of other growth factors that are involved in blood vessel formation, of which one is called angiopoietin, and that acts through a receptor called Tie2. And the reason I'm telling you this is because we've discovered that by monitoring Tie2 in the patient's plasma, we can work out who's benefiting from bevacizumab. So the first study that we did was ICON 7, which is an ovarian cancer study. So what we looked at here, on the horizontal axis, we're looking at the patient's time on treatment, and on the y-axis, the vertical axis, what happened to the concentration of this molecule in the patient's blood when we gave them different treatments. So when the patients had chemo only, the level of the Tie2 went up and pretty much only came down towards the end of treatment. But when we gave an anti-blood vessel drug, bevacizumab, the concentration of Tie2 came down and stayed down for as long as the drug was working. When the effect started to wear off, then we saw the Tie2 level in the patient's bloodstream go back up. Because we really wanted to find something that worked in all cancers, We also looked at bowel cancer as well, and this is a false colour image of a patient who's got a tumour in the liver. And what we showed there was that the change that we see in the bloodstream paralleled exactly what was going on inside the patient's tumour. So there was a reduction in blood vessel inside the patient's tumour, as you can see by that reduction in orange and red, and that paralleled exactly what we were seeing in TIE2 in the patient's blood, suggesting that what we were seeing really reflected what was going on in the patient's bloodstream. Now, fast forwarding 20 years, we have shown that when the patients have a reduced level of TIE2 in the bloodstream, that equals control of their tumour blood vessel. If it doesn't change, like I'm showing you in the blue bar on the left-hand graph, if there's no reduction or an increase, then the drug isn't working. And that's important because some of these drugs have a lot of side effects. Anybody who knows anybody who's had bevacizumab will know it's not a walk in the park, and the tablet versions are also pretty tough to take as well. And we can say, like I showed you with the red line here, that we know when the effectiveness of the anti-blood vessel drug has worn off because the Tie2 level goes back to the pre-treatment levels. So over the last 20 years, we've actually looked at this in 4 different tumour types. And the reason that we did that was because there have been so many false starts. Everybody's come up with their molecule that tells you whether Avastin works or not. And therefore, before getting too excited, we needed to really demonstrate that this worked in other disease types. And in fact, what we've done now is shown that it works in ovarian and bile duct cancer, bowel cancer, and again, a couple of weeks ago we presented in Germany in endometrial or womb cancer as well. And to try and really make this generalizable, we looked at antibodies like bevacizumab as well as the tablet anti-VEGF drugs like cediranib as well, and it works for both of those. Some of you may have been, for which we're very grateful, taking part in VALTIVE-1. VALTIVE-1 stands for Validation of Tie2 for VEGF inhibitors, which is a CRUK-funded study. And what we're doing is studying ovarian cancer in great detail because the first clue that we had about Tie2 was our study up on the left, which was in ovarian cancer. So we weren't as, when we set it up, we didn't anticipate this was going to happen. So we've repeated that. And that study has now completed recruitment. Again, many thanks to all of you for that. And randomized studies are being planned. In a sense, it doesn't really matter which studies, which tumour type we study, because looks like it works across all the different tumour types, but we hope to do one in ovarian cancer as well. Okay. Now, just moving on to my last slide. I've mentioned loads of different trials, drugs, and the question is, how do you access them? So, about 2 years ago, the NCRI group stopped working as that. NCRI stopped working, and a new group was formed called the Gynae Oncology Trials Group, UK, GTG UK. And I'm going to leave this up, so you can photograph the links if you want to. But you can find out which trials are going on in gynae cancer in the UK through that website. So at the moment, we haven't got a huge number going on at the moment, but there's a load coming through, particularly on antibody drug conjugates. So we're adapting doses based on CO125. The low-grade ovarian cancer studies, the RAMP studies that I mentioned, Gloriosa, the Merv-bevacizumab combinations. There's drugs that are being developed to take advantage of a genetic mistake based on a protein called ARID1A. That includes clear cell as well. And platinum-resistant antibody drug conjugates are coming through. So when you're saying, how can I access these trials, there's 2 ways to do it. Look at the GTG website. That will tell you who's doing what study where in the UK. The second thing you can do is go to a site which is the Global Clinical Trials website, which is clinicaltrials.gov. If you go to that site, you can find anything that's going on globally. Obviously, you will find something that's down the road, but it's a very good site to tell you what's going on and who's doing it. And you can look up eligibility criteria to see if the studies suit anybody you know. But these 2 sites should enable you to access some of the drug treatments that I've been talking about today. Thanks very much for listening.